You are now watching the 84th Annual NAACP New York State Conference Convention.
There's an old saying, health is wealth. Health is considered the most valuable and precious commodity for every individual. The global pandemic has hit our communities hard this year. So where do we go from here? Here to answer that question and present this year's health workshop is our health chair, Lorraine Brathwaite Hart.
Thank you, Tracy. Good morning and welcome to the NAACP New York State 84th Conference Convention. My name is Lorraine Brathwaite Hart, and I am the health chairman for the New York State NAACP Conference. Thank you for being present for our health workshop titled COVID-19, Pre-Existing Conditions, the Role of Nutrition and the Social Determinants of Health that Created the Devastating Outcomes in Communities of Color. The mission of the NAACP is to ensure the political, educational, social, the economic equality and rights of all persons, as well as to eliminate the race-based discrimination. Today, our discussion will include working to make sure that we address the disparities that have been laid bare by COVID-19 pandemic. By now, we all know that the pandemic has hit communities of color, particularly the African American community, disproportionately hard. African Americans are infected with COVID-19 at nearly 3 times the rate of white Americans and are twice as likely to die from the virus. With the rapid spread of COVID-19 throughout the country, New York State quickly became the epicenter of the virus. In New York State, those who are Black and Hispanic make up over 60% of the total COVID deaths, so far experiencing the most severe symptoms and outcomes. To properly address these issues, we've put together a panel of experts who will be willing to answer your questions at the completion of all presentations. Please submit all questions in the chat box, and we will answer as many as possible today. Our first presenter will be Dr. Demisi. He's an MD, PhD, Dean of School of Public Health at SUNY Downstate Medical Center, and is a nationally recognized academic public health leader and researcher in the field of health disparities and minority health, perinatal health, and cancer, who is committed to the success of young scientists. I now present to you Dr. Demisi.
Good day, everyone. I am Katao Demisi, Dean of the SUNY Downstate School of Public Health. It is my great pleasure to present at this convention and also to be part of this panel. In the next 15 minutes, I will briefly speak about the coronavirus and its outcomes. I will also highlight racial and ethnic disparities in the outcome of the disease when appropriate. The diagnosis of COVID-19, the primary manifestation involves the lower respiratory tract. A large majority of cases present with fever and cough. Dyspnea sometimes may be a presenting feature in severe cases. A small percentage of patients may also have gastrointestinal symptoms, including diarrhea. In some cases, patients can progress into pneumonia, and in some cases, acute respiratory distress syndrome is a major complication of COVID-19 pneumonia in patients with severe disease. In a certain percentage of the population, asymptomatic cases of COVID-19 exist, and these people are significant transmitter of the disease. And the symptoms in these patients, if they develop it, can be mild and sometimes occur mainly in young patients between the ages of 18 and 29-year-old. The epidemiology of COVID-19, the incubation period typically ranges from 2 to 14 days in 98% of the population, with an average of about 5 days. although there have been cases with incubation period reported up to 24 days. The basic reproduction number, R0, is a measure of that quantifies the epidemic potential of the virion or the pathogen, and the number is defined as the average number of persons, an infected person can spread the virus to. The basic reproduction number for COVID-19 ranges between 2.4 and 3.3. This number varies in relation to mobility, containment measures, susceptibility, and population at risk, among other parameters. And the translation of this is each infected person can infect 2 or 3 other people with this basic reproduction number for COVID-19, unless there is a herd immunity. In addition to age, a further comorbidity that is potentially associated with severe illness are hypertension, obesity, diabetes, cardiovascular, and lung disease. And as you know, most of you know, these conditions occur more frequently among the minority populations, among African Americans, and among Latinos. So hospitalization, COVID-19 hospitalization, as of September 20th, about 6,999,955 cases have been reported. And as you can see the graph, hospitalizations are more common in the older age group and has been decreasing since the epidemic apex with 2 spikes. Cases are disproportionately higher in Black and Latino neighborhoods. The Bronx, Brooklyn, and Queens in New York City have higher rates of disease than Manhattan, and the Bronx has the lowest levels of income and also education and the highest proportion of Blacks and Hispanics. On the other hand, Manhattan is predominantly white, most affluent borough of New York City. Because of the high rate of infection, the poor neighborhoods exhibit a high rate of antibody positivity. Whether this high rate of antibody positivity will provide protection during the second wave of the epidemic remains to be determined. Black or African Americans, Hispanic and African American Indians have a rate of hospitalization that is about 5 times than whites, as you can see on the slide. A meta-analysis of 37 articles with 24,983 participants showed that the rate of ICU admission is about 32%. As you can see on the slide at the bottom, where you have the pooled analysis. And the meta-analysis also reveals that the pooled prevalence of mortality in patients with coronavirus disease in the ICU was about 39%, with a confidence interval of 34 to 43%. As of September 20th, about 204,110 deaths have been reported in the U.S., and the U.S. now has, on average, about 700 deaths a day. Black or African Americans have about twice overall death rates than whites. American Indians or Alaskan natives have a rate that is about 1.4 times than that of whites. Hispanics and Asians appear to have similar death rates as whites. However, the overall death rate masks important age-specific death rate information, as you can see from this slide. As you can see on the table, African Americans or blacks have a death rate about 6-fold, 8-fold, and 9-fold higher than whites in the age groups 0 to 24, 25 to 34, and also 35 to 44 respectively. The death rate is also significantly higher among Latinos than whites in these age-specific groups. Similarly, this slide also shows you blacks have a 7-fold, 6-fold, and 9-fold increased death rates than whites in the age group 45 to 54, 55 to 64, and 65 to 74 respectively. And a similar pattern is also evident among Latinos. The disparity in death rates among blacks and Latinos is very minimal in those patients who are older than 75 years of age. I will speak a little bit about special populations, and I will talk about pregnant women now. In comparison with non-pregnant women of reproductive age with COVID-19, pregnant women with the disease were less likely to manifest symptoms of fever and myalgia, and it is very important for obstetrician to remember this because the presentation of pregnant women with COVID is a little bit different than the general population, where the majority of patients have fever and also myalgia. Maternal risk factors associated with severe COVID-19 include age, high body mass index, chronic hypertension, and pre-existing diabetes. Pre-existing maternal comorbidity was reported to be associated with admission to an ICU, and the need for invasive ventilation has been demonstrated. In pregnant women with COVID-19, compared with pregnant women without the disease, the odds of preterm birth was much higher, but there was no difference in other maternal outcomes. The risk of admission to the neonatal unit is increased in the neonates of mothers who were born from COVID-19 women. COVID-19 in children, the earliest report of COVID-19 infection in children suggested a benign course, but later a report from the United Kingdom, New York, revealed a multisystem inflammatory syndrome in children associated with COVID-19. The syndrome was associated with inflammatory conditions with a Kawasaki-like syndrome accompanied by hemodynamic instability and hemodynamic shock. All of the children with this syndrome required an ICU admission and severe care. In conclusion, in an editorial, David Williams stated that COVID-19 is a magnifying glass that has highlighted the larger pandemic of racial ethnic disparities in health. In addition to healthcare access and quality of care, social determinants of health, including systemic racism, need to be addressed to flatten this epidemic curve of racial and ethnic disparities in health. Thank you very much for your attention.
Our second presenter will be Eric L. Adams, Brooklyn Borough President, who is on a mission to tackle one of the most stubborn health problems in the country, chronic disease in the African American community. A former diabetic himself, President Adams was able to reverse his condition by switching to a plant-based diet and has partnered in the past with the NAACP New York State Conference to provide educational sessions on how to prevent and reverse diabetes to the membership. President Adams will address diabetes and obesity as they are rampant in the African American community and how it directly factored in the high rates of COVID-19 infections and what must be done to address these factors, which are driven by food deserts and institutionalized racism that exists in the African American community.
I thank the NAACP so much for having me today. You are so important as an institution. For far too long, people believe that eating healthy, whole food, plant-based, they thought it was a white thing. They thought that it was too expensive to do. They thought that why would you try to take away soul food from us? But now, with having you involved in this conversation, the oldest civil rights organization in America, it changes the dialogue. It makes us re-examine how we started a diet made out of food that our ancestors were forced to eat into slavery, that we took it and handed down it in our recipes generation after generation, causing the destructions of our lives, losing so many heroes and sheroes in the process, such as Ken Thompson, the first black district attorney here in the borough of Brooklyn, dying at 50 years old from colorectal cancer, food-related disease. So many great heroes and sheroes we lost because of the food that we have consumed. When COVID-19 first hit New York City, immediately I thought about 9/11 and how important it was to be ready to have a rapid response. And so I decided to move into Borough Hall, put a mattress on the floor, and set up a command center so I could immediately respond to the calls of service and needs that were basically taking place all over the borough of Brooklyn. Little did I know how important it was to be able to have a clear understanding of what was happening on the ground. And I spent so much time on the ground, going to NYS developments, to hospitals, supermarkets, interacting with people who was either sick and shut in, were unable to have the basic supplies. And it was a real first-hand look at the impact of COVID-19 on the various communities, particularly the black and brown communities. As I moved around the city and borough during the peak of COVID-19, I started to see a pattern: diabetes, heart disease, respiratory issues, asthma. It was clear that people who were becoming sicker and sicker from coronavirus were being impacted because of those pre-existing conditions. And I knew then that all the work we were doing to address prevention and reversal of diabetes and other chronic diseases were so important. It was as though we were expecting something like this to happen because those pre-existing conditions made over 90% of the people who were hospitalized had pre-existing conditions, and over 90% of the people who died had pre-existing conditions. We have to get a handle on it and prevent those pre-existing conditions from happening and to reverse them when they do take place. You know, when people ask why was there disproportionate negative impact on black and brown communities because of COVID-19, there are many reasons why. One, there was a clear, slow response nationally for communities of color to have the proper response, testing, PPEs, information, all of the basic things that were needed. And then second, black and brown communities suffer at a larger rate than other communities due to pre-existing conditions. Our numbers are higher in heart disease, diabetes, hypertension, high blood pressure. COVID-19 did not create those crises. It revealed the depth and extent of those crises. When I think about this conversation, it hits home. I was diagnosed with type 2 diabetes. I lost my sight in my left eye. I was losing my sight in my right. The doctor said I was legally blind and I had to turn in my driver's license. Had permanent nerve damage in my hands and feet, tingling all the time, high blood pressure, high cholesterol. really going through a terrible state, had an ulcer that sent me to the doctor originally, only to find out that it was diabetes in its late stages. And it was only after deciding that I didn't want to be on insulin the rest of my life that I decided to do something different. And I reached out to those health professionals that believed in disease reversal. Instead of just sick care, they believed in real health care. And they gave me information to go to a whole food, plant-based diet. I did, and 3 weeks after doing so, my vision returned. 3 months after, my nerve damage went away, my diabetes went in remission, the ulcer that originally sent me to the doctor in the first place went away, and I dropped 30 pounds without trying, but my body felt amazing. And the bloated feeling, the tired, lethargic feeling, all of that went away when I changed what I was putting in my body. Because my mother was diabetic, and she was diabetic for 15 years and 7 years on insulin, I thought it was hereditary and it was my DNA, and it wasn't my DNA, it was my dinner. Because when Mom started a whole food, plant-based diet, within 2 months, Mom also was told she can get off her insulin as well, and she was over 80 years old. It's unfortunate when you look at the issues around pandemics and health and chronic diseases. One thing that's missing from the conversation is food. We must really infuse food and the proper food into this conversation. It is so important. It must be done inside our houses of worship. We must make sure we have proper nutritionists to instruct people how to eat well, behavior scientists to give people the support they need as they attempt to change their diet, to deal with the addictive behavior of sugar, fat, salt, and processed food. It is unsustainable to continue to live in the healthcare system that we have. We spend 80 cents on the dollar in America on chronic disease. We have over 30 million Americans that are diabetic, 84 million are pre-diabetic. Diabetes is the leading cause of blindness, leading cause of non-trauma limb amputation, and one of the leading causes of kidney failure as well as heart disease. If we get diabetes under control by using healthy eating and lifestyle changes, we can change the entire trajectory that we are experiencing. Food must be not only part of the conversation, it must be at the center of the conversation. There's so much we can do daily to take one step at a time. First, become knowledgeable about the impact of food and how it impacts your quality of life. And then do something simple as having a meatless Monday. Have a day, one day of the week, where you are tasting healthy food and see how enjoyable it is. And then do research on spices and look at the power of spices. Spices like nutmeg and turmeric and cumin and cinnamon. And then try a new meal after a few weeks. Cut out one bad meal a week. You can start with breakfast, and then the next week you do breakfast and lunch, and then the next week you do breakfast, lunch, and dinner. And experiment on different meals to get your taste bud used to not being oversaturated with highly processed food. So it's about taking small steps. And when you take those small steps, you would notice how your body would start to adjust and to adapt to a new way of living and how good it feels. Oftentimes when we go to the doctor, we turn over the health to them. Nowhere else do we do that in our lives. Well, even when we go to the mechanic, we make sure he's treating our car right. If we go to the hairdresser, we make sure that it's cut correctly and handled right. That's how we should treat our healthcare professionals. They are part of your health team. They're not the owner of your team. You are the owner of your team. You must get instructions and advice. And if any doctor you visit that does not believe in disease reversal, you should look for another doctor. Your doctor must take instructions from you and guide you through the process in a very safe and healthy way. That's what Mom did when she wanted to get off her insulin. She didn't immediately stop taking the insulin. She instructed her doctor this is what she wanted to do, and she was going to try a new lifestyle in the process. And he slowly reduced her dosage until she no longer needed it anymore. But she needed the doctor to cooperate with her and not the doctor to tell her what she couldn't do. That is how you should treat your health care professionals, as part of your overall health team. And you are the person that's in charge of that team. You being a part of this conversation all of a sudden makes people take notice that if an organization as powerful, as thoughtful, and as much of as an influencer as you are, say we need to start looking at food in our diet to reverse the conditions that we are experiencing, it is going to be a wake-up call for us all. I thank you for allowing me the opportunity to share this moment.
Next, we will have Dr. Sally Fu. Dr. Sally Fu is an MD, MPH, MBA, FACP, Division of Nephrology and Director of Kidney Transplant Program at SUNY Downstate. Dr. Sally Fu will address the social determinants of health that include inequity in healthcare delivery in the African American communities.
My name is Dr. Morris Salifu. I am professor and chair of the Department of Medicine at the State University of New York, SUNY, Downstate Health Sciences University in Brooklyn. I also direct the Brooklyn Health Disparities Center, which is dedicated to the elimination of health disparities in Brooklyn, New York. Today I'm going to be examining the social determinants of health and its impact during the COVID-19 pandemic. I'll be discussing the differential impact on minority communities, local and national data. I would also be linking these comorbidities as everyone knows them and how the social determinants of health actually lead to comorbidities, and also some lessons learned and possible interventions, and then some take-home points. COVID-19 pandemic is one of the worst pandemics of our lifetime, affecting millions and millions of people worldwide. In the United States, more than 6.5 million people have been infected right now, with more than 193,000 people dead. Most of the patients who were affected were African Americans, Latino, Hispanic Latino, American Indians, Pacific Islanders, and Native Alaskans, compared to Caucasian populations. And the mortality also followed the same trends. There were some studies done in the earlier parts of the peak of the pandemic. That was in March and April of 2020, and showed that the outbreak was worse in lower income areas compared to areas with higher incomes in New York City, as an example. And similar studies showing that, from the New York Times, showing that the more the number of people in the household, the more likely there were to be higher levels of infections. In New York City, as an example, the number of deaths, you could actually map them by zip code, and you could tell where the infections were actually occurring the most. You can see in maps of zip codes, the one that has the highest, the zip code that had the highest impact in terms of infections and mortality was a zip code in East New York, the Starrett City area. Nationwide, African Americans were impacted the most, and Hispanics as well. African Americans make up about 12 to 13% of the population, but 21% of all the infections and mortality nationwide. And if you look at the number of deaths in New York City as an example, the black population and Hispanic population were more likely to die from COVID-19 infection, twice as likely than for whites and Asian patients in New York City. It so happens that if you actually map out the COVID-19 infections and the zip codes and map the infection to actually where people live, it's startling to find out that the higher infection rates actually occurred in areas where you had more minority patients like African Americans and then Hispanic Latino in New York City. Across the nation, Black Americans face alarming rates of COVID-19 coronavirus infections. As an example, in the state of Illinois, African Americans make up about 50% of the population, but 43% of the COVID-19 related deaths. In Michigan, about 14% African American, and made up about 40% of the COVID-19 deaths. And in Louisiana, African Americans made about 33% of the population, but make up about 70% of the coronavirus deaths at the peak of the pandemic, in the early parts of the pandemic. So the fact that African Americans and Hispanic Latino have high infection rate and high mortality rate is not surprising, and people have come up with various kinds of explanations, right? Is it because these populations have high comorbidities, hypertension, diabetes, asthma, COPD, that is chronic obstructive lung disease, kidney disease, and so on and so forth? Or is it because of lack of adequate access to PPE, the personal protective equipment in minority-serving hospitals and facilities? Is it because of high risk of uninsured patients? Is it because of high risk of patients not being referred to for symptomatic disease, such as flu-like symptoms? People are just delaying in getting to their doctor, whereas in the Caucasian populations, people would rather go to their doctor and find out why before anything happens. Is it because there was less testing and late presentations, or lack of early communications about seriousness of COVID-19? Or is it because of confusing messages during the early parts of the pandemic, allowing false rumors to fester that black people are sort of immune and not likely to get COVID-19? And then there was another myth, such as colored people are not washing their hands. There was one of the Ohio Senator, Steve Huffman, who was cited as saying that colored people not washing their hands, and he was fired from his job. That is certainly a myth and not true. So there are so many questions, so many postulations around why African Americans, Hispanics, or in general minority populations had more infections and deaths than the majority population. So I'm going to discuss a little bit about how we actually connect the comorbidities and linking, how we link that with the social determinants of health. If you talk about population health in general, you're talking about 4 or 5 different kinds of things that bring health to a population. The first one is your genetic makeup, but that actually plays a small part in the population health. Then the next one is your societal and social characteristics. What is actually happening with those societal and social characteristics that make you a whole person? And that is probably the bigger portion of what determines the health of a population. Then you have medical care. Hospitals, health facilities providing care is a portion, but it's not the biggest portion that determines the health of the population. And how you behave in that setting would also determine the health of the population. So among those factors, genes, your social characteristics, medical care, and health behaviors, the social characteristics tend to play the major role in how the population, not the individual health, but the health of the population, how that is determined. And by that we mean the conditions in your social, the physical, and economic environment in which people are born, live, work, and then age. So what are they? They are how you got educated in the system, economic stability, neighborhood and environment, health and healthcare, and social and community context. So for example, in education, early childhood education is so paramount. So the later you start early, the later you start childhood education, the more likelihood that children are not going to catch up in the educational system, and therefore they would lack some of the things that would make them get to higher education, be healthy by that. Economic stability is very important. Poverty, housing, security and stability, employment, food security, transportation are all aspects of economic stability that are quite different between minority populations and the rest of the population. Neighborhood and environment, how we are able to afford housing and quality housing, environmental conditions, access to healthy foods, crime and violence, all those neighborhood environmental factors also determine how a population is able to determine its health. Then you have the health and healthcare, access to healthcare, gaining entry into the health system. That is how people actually are able to get to a doctor or some healthcare provider to be able to understand what their problems are and to be able to solve them. And then understanding what the doctors or the health care providers actually tell them, which is called health literacy. And then the social and community context depends on the social cohesion, your civic participation duties, perception of discrimination and equity, and incarcerations and institutionalization. All those things also impact how the population perceives itself as being healthy. So we're going to take one after the other and examine them. In terms of education, if you look at education in terms of blocks of less than 12 years and more than 12 years, the number of, Caucasian or white people who advance from less than 12 years of education, that is less than high school to high school and then to college, actually progressively goes up and up and up. It actually goes up to almost like 65%, which is very good. But this is in contrast to Hispanic Americans, where less than 12 degrees of education actually appears to be very, very high, and it actually gets lower, less than 30% as people get into colleges, which is very a big problem in terms of health. And then for blacks, it's almost following the same pattern. There is 12. Most people are able to get to 12 years of education, but the number drops from that point going to colleges. So the number of people actually eventually ending into colleges for the first time is much, much lower in the minority population than in the majority population. Economic stability, I'll give some examples on economic stability. This is, I'm showing a chart here that is very interesting. It's actually looking at the perception of how people actually perceive of their health as being fair or poor. And the higher your income level, the more likely you are actually going to perceive your health as being actually good. And the lower your income level, you are more likely to perceive yourself as having poor health. So here, if you are earning less than $15,000 per year, you're more likely to perceive your health as being fair or poor. So there's a direct correlation between how much an individual or family makes and how they actually perceive themselves as having fair or poor health. Unemployment is also a big factor in the social determinants. Unemployment, you can see over the last, from 2006 to 2007, about 11 years of data, blacks have always led the charge in terms of unemployment. And of course, this has a significant direct correlation with health. If you look at the persons below the federal poverty level, you see that 21% of African Americans, black African Americans, and 18% of Hispanics are below the federal poverty level, compared to 8% and 10% of Asians. That's almost double the definition for federal poverty level for minority populations. And if you look at the average income by education, it's not surprising that, of course, the higher your education, the more income you're going to make. So if you have a population that is not actually able to make it up to the highest possible levels, of course, the incomes in those populations will be much, much lower. And that also has a direct link to how healthy that population is going to look like. And then there is the effect of homelessness in the United States. This is a big problem with Native Hawaiian and Pacific Islanders leading the charge, and then blacks, then American Indian, Alaskan Native, and then two or more races before Hispanics. And of course, whites and Asians have the least in terms of homelessness in the United States. Again, this has significant impact in health and how the population perceives of health. And of course, if you go by the cities and which of the cities has the highest level of homelessness, New York City leads the charge, followed by Los Angeles and a number of other cities. So the big cities tend to have the problem in homelessness, and that also has to play into how the population in those cities actually plays out. Then you have the health and healthcare, that is access to healthcare issues. So I'm going to give an example such as health insurance coverage. I'm going to show you this chart looking at health insurance coverage between 2013 and 2017. And you see the uninsured rates for Hispanic Americans is just unbelievably high as 22%. More recently has gone down a little bit, but there's no reason why this uninsured rates should be this disparate. And then For African Americans, it's about, it was 90% in 2013. That has come down now to 11%, but it's still very high compared to white population, which is around 7%. Now, all these things have to do with, how the population actually lives. So there is this factor called the life expectancy. If you look at the life expectancy by race, African Americans in general would live shorter than white Americans, and that is really very sad. And black Americans, for sure, are living at least 5 years less than the general population. Black women and white women tend to actually have an advantage in life expectancy, but the white women tend to live the most. They live an average of around 82 years, whereas the black women live around 77, 78 years. So there's still a difference even between the women, even though the black women do much, much better than the black men by a wide margin. So all these, social determinants, we call them, have a historic context that is driving them. And the historic context has to do with the beginning of slavery and then to the Jim Crow laws, which we don't want to go to the detail, but it's basically segregation, white facilities and black facilities. Then there was some modification along the line, Plessy and Ferguson in 1896. Then in 1946, there was another modification called the Hill-Burton Act, which was the first public funding for hospitals prohibiting discrimination, but allows for separate but equal facilities. Then in 1964, we had the Civil Rights Act, which then said that prohibition of any sort in any institution is basically discrimination is basically prohibited. And if you wanted to get the federal funding, you can do that. And really, that was the first time that there was actually the same hospital with blacks and whites mixing in one hospital in one wing. So that is not too long ago. And then in 1965, then you had the Medicare and Medicaid. Rules came out that then formalized the Civil Rights Act, made it actually put into operation. And now we can benefit from that, where you go to a hospital, you don't see that separation any longer. But this is not long history. It's only 1965, actually after I was born. So this is still a problem. People are still practicing these problems, and then there's always this perception that affects people's mindset. In terms of implicit biases that they bring to the profession or to caring for people. And then finally, in 2010, we have the Affordable Care Act, which was also a healthcare law. The goal of that law was to increase the number of people who were insured, and it was able to get at least 20 million people or so insured in the country. That was a very nice intervention, by the way. Then there was another event in history that created more of segregation than what we would have expected, and that was dubbed the redlining during the 1929 housing collapse. During that housing collapse, the financiers gave money to people that they thought would pay back, and did not give loans and other things to people that they thought would not pay back, and automatically that just separated the communities into low-income and high-income places or zip codes, and so those communities persisted. So even though the redlining was made illegal in 1970, the negative effects persisted until date. There are so many communities that are still segregated because of that. Then there is this mistrust of the healthcare system issues based on what the medical community, the history did to African Americans as an example. The examples are more, easy to say because we have more documentation of them in African Americans and blacks, so it's much easier to mention those examples. For instance, in 1846, you have a surgeon, doing surgery on black women without anesthesia. Right, and we got to know only more recently, and then this is the doctor who was really, really revered in the gynecologic world, but in 2018, that was revealed, and then his statue in Central Park was removed. Right. Then there was this mistrust issue that everybody knows about, the syphilis study, which took almost 40 years, from the 1940s to the late 1970s. Black men were experimented with syphilis just to understand the natural history of syphilis without medication. So this just sows seeds of mistrust in the healthcare system. People think that they're going to be experimented upon, and then it makes it difficult for people to participate in clinical trials and the like. And then we have another story of Henrietta Lacks, whose cells became immortal, became very significant in cancer research, but the family didn't even know that was happening. It saved millions and millions of lives. Again, using somebody's parts without letting the family know was a huge mistrust issue in the community. So what do these historic aspects, what do they mean to health disparities and then the social determinants of health? What it means is that there was delayed wealth accumulation over the years, and there was persistently, and even up to now, persistently segregated and poor neighborhoods. There is also biases and stereotype issues that just promulgate across the system. There's also the mistrust issues. And of course, there's a high stress, allostatic load because of what I just explained. And this results in poor health status and high risks of comorbidities. You cannot have this level of stress in your community and not expect to have high risks of comorbidities, hypertension, diabetes, and the like. So what are the lessons learned? The lesson is that we have to practice the concept of equity. For sure, it's very hard to get everybody to be on the same footing. Equality is going to be very hard to achieve because nature is never going to be equal to everybody. And we don't want reality where everybody is just, the people who have it just have too much, and then the people who don't have just have no chance of ever having it all. So what we are preaching is just basically equity, not taking anything away from the people who have, but making sure that those who don't have whatsoever are able to manifest a little bit of the ability to achieve or attain a certain amount of health. So that brings me to now to the National Academy of the Sciences, National Academy of Medicine, which was in the 2000s called the Institute of Medicine, came up in 2001 with the report that was entitled the on equal access. And basically what they did was try to define what this health disparity actually comes from based on the historical aspects and all that. Where actually, if we were to measure, where is it actually coming from? So from the context of health quality, the difference is actually coming from the healthcare systems in terms of summary. It comes from the complexity of the healthcare systems and also from discrimination. And that, I mean, biases, stereotyping, and on clinical uncertainty. The discrimination issues are just historic, and there is no time for me to be able to explain that here, but I'll be happy to take questions at another time. But those issues is what actually creates the disparity. So now coming back to COVID-19 pandemic, minority communities actually face a lot more challenges than the majority community in the pandemic. There were some personal hygiene issues because of housing issues, not because of actual people not being able to take care of themselves, but housing issues is a major problem. There was also the personal protective equipment issue. There was social distancing issue. And for that, I mean, there is shelter in place. You have to be home, right? You have to be home. Schools are closed. We're limiting the operation of non-essential businesses. And then we want people to work from home. These are all social distancing policies that were put in place, but they may or may not have negative impact on minority communities, but I think they did. For instance, the challenges were no disposable income. If you are from a minority community, you are working a small little job, you don't have disposable income, and you are asked to stay home, and then you're asked to take care of your child, but at the same time, you have to make sure that you are paying your light bill and all that stuff. That is just a big task, right? You are not working, and you are being told to do what you're supposed to be doing when you are working. That is just inconsistent. And these people don't have flexible work schedules. Work cannot be done from home. Mostly essential workers. No paid leave to take care of the kids. All the hours are cut short. There are layoffs, furloughs, and then you end up not being able to pay your rent or utilities. And then that compounds the poor housing conditions. And therefore, your choice is really between your food and health and all this, right? So what will you choose? Of course, you're going to choose the food, and that's it. So how are you going to afford the rest of the stuff that's going to take care of your health? All right. So I think we have to then think about things that we can do to impact directly the minority communities when we're in pandemic situation, because those communities are actually the community that we actually think they're essential workers. They have to come out and work, right? We actually think that they are essential workers. So there is a lot that is going on in their plate that needs to be addressed. Okay. So I think one of the things that was done, which is very commendable, was the economic stimulus, right? Which is very nice. We have to do more research on that to make sure that minority communities are actually getting the money that that's actually given to all these corporations and big businesses. We need state and local leadership to protect the workers and place moratoriums on evictions so that people can have their homes, protect the homeless people and increase affordable housing, place moratorium on utility shutoffs, enforce safe and healthy homes regulations, and ensure access to food and other necessities. And then all together, right? It's not just the government and the local government that can do everything. We have this socio-ecological model for health solution that involves everybody. So there are solutions from the individual level, there are also solutions from the policy level, and also from the organizational levels, as well as community and between the families. But for individuals, knowledge is key. Individuals must have knowledge and seek knowledge to understand what this disease is all about so that they can better take care of themselves. While, as an example, policy from government and other organizational structures should be designed specifically to address minority health during pandemics, especially the COVID-19 pandemic. So I'm going to give an example in closing. As an example, what these social determinants of health actually mean and how we could actually have a futuristic system that would actually address that. As an example, you have a middle-aged patient, doesn't understand that much, poor health literacy, unemployed, homeless, uninsured, has comorbidities, and is admitted for alcohol withdrawal symptoms, as an example. So let's say we had a futuristic system in place with a futuristic electronic health record system that can capture all the social determinants of health that the patient has, and then can calculate the social determinants of health risk score, right? And then this futuristic electronic health medical record will actually, pop it up and say, oh, this patient has a risk score of, let's say, 9/10. And then in the community, we're able to then find out which of the community-based organizations can actually solve this patient's problem, and then we connect the patient to care. That would be the ideal system that would actually address these social determinants of health. The hospitals alone cannot do it, and they are not designed to do it. And government alone cannot do it because they're not designed to do it. What will do it is going to be a linkage between hospitals, community-based organizations, and a system that actually links the two together. So in summary, the COVID-19 pandemic continues to ravage the USA and the world as we see it. Minority communities are the hardest hit. Social determinants of health play a critical role, and solutions must be specific in addressing these social determinants to combat the pandemic and to ensure health justice for all. Emergency federal assistance will always be needed to keep people paid while in shelter in place, but employers must also do their part to release such assistance to be effective. Hospitals must put systems in place that emphasizes identification and solutions to social determinants, and research is needed to identify effective methods of health justice for all. Thank you.
Thank you. In closing, the COVID-19 pandemic has hit us so hard that it is virtually impossible for anyone not to know of a friend or family member that hasn't been affected by the disease. New Yorkers know how to stay corona-free. We've been through the worst of time. Most of all, the disparities and inequities that have brought us to this tragic point in time will continue to plague the same exact communities if we do not pressure and hold accountable government and local officials to make the changes needed to prevent this from ever happening again. The power of change is within our communities. It lies within us. By submitting your census forms and casting your votes on November 3rd, you're ensuring having a voice at the table. Guard yourself, eat healthy foods, protect your mind, wear your mask, socially distance, wash your hands, and above all, be good to yourself. Because COVID-19 is like a thief in the night, come to take your most valuable possession, which is your life. And should you survive it, it may leave you with a chronic, debilitating health condition. And above all, remember this year's NAACP motto, which is that we are done dying.
Now, our panelists are going live to answer some of your questions.
Well, hi. That was a powerful health presentation. And we really want to thank Lorraine and her panelists. I will tell you that I know everybody is going to be calling Eric Adams, but I'm calling him first. So what I think that we should do is I'm going to turn it over to Lorraine, and Dr. Salafou is here, and also Eric Adams. And I think what we should do as a New York State conference is I will challenge the Long Island region against all of the other regions, and we're all going to sign up for a plant-based diet, and then we'll see which region is going to lose the most weight. So game on, everybody. Game on. Lorraine?
Yes. Okay. So thank you, everyone, for having been on today. And this is a great opportunity for you to ask questions and have President Adams answer them, as well as Dr. Salifou, who is also on, but I don't see him on the screen right now. So I don't see any questions yet, but there were several comments. So I am going to start with you, President Adams. Well, President Adams. Okay, so how do you think, I mean, you have done an excellent job presenting how to start taking care of yourself better from your own experience. What do you say to the overall health community, the hospitals, the community-based organizations? How do we work unified to address this issue so that others can understand that this is doable? Because most people feel, I can't do that, I can't do that. So what would you say?
And first of all, I really thank the NAACP, what they have been doing and just leaning into the unknown to really embrace this new concept and new way of living. And as I indicated in my video presentation, mommy has 6 children and she loves them all, but she adores me. I'm her favorite child. And when I saw her injecting herself with insulin for the 7th year, and I looked at her face and I saw her grimace, and I just said, God, I'm not a doctor. I want to do something for my moms. And, the Creator has a way of really answering your questions. And little did I know I was hit with the same, chronic disease. And so through my life, I'm able to turn around hers. And I think the example was perfect. Mommy was 82 years old, 15 years diabetic, 7 years on insulin. The doctor that was treating her at the time dropped her as a patient. When she stated she wanted to get off of insulin, he said, if you try to do that, you need to find yourself another doctor. So it's clear when you look at only 25% of the medical schools in our country have one course on nutrition. We're taught prescription, not nutrition. And because when you look at the federal government, when you look at the pharmaceutical industries, you look at really the belief in our country is not healthcare, it's sick care. How do we sustain sickness? Mommy was on 9 medication. I walked out of that doctor's office that day. I was walking out that office with 7 medication, 1 for my eyesight, 1 for my ulcer, 1 for my high blood pressure, for my cholesterol, 3 for my diabetes, including insulin. I thought I was a miniature Walgreens with all that medicine that I had when I walked out. But in 3 weeks for your eyesight to return. So what we must do, and if you look at the wonderful presentation that the doctor just gave, look at all of them. Let's say you start peeling off the things that are part of the social determinants of health. Let's say you peel off the homelessness, you peel off the education, you peel off all the problems that you have that are part of the social determinants, but you still have the standard American diet. You still have the crises.
Exactly.
So it doesn't go away if you remove those other social determinants. You still have a crisis because we have brothers and sisters who have higher degrees of learning, professional occupations, still having heart disease, still having diabetes, still on drugs. It's the food. And we must incorporate that in our school system. We must stop feeding the crises. Hospitals need to provide healthy foods. Schools must give healthy food. We got rid of processed meat here in New York City, no longer sell it and serve it in our schools. We must make sure our Department of Correction is serving healthy food. Government can't feed the crises, and that is where we must go. That must be the starting point of the plan, that I can't tell you what to put on your grill in your backyard, but my tax dollars should not go to feeding the crises.
Exactly. So one other question. What would you say regarding COVID? Did COVID expose the problem, or did it just magnify the problem?
And we all said that. I believe all the leaders, probably including yours, stated that, you know, COVID didn't create the problem. It just magnified or exposed the problem. And here's the failure. We gave out millions of meals because people were shut in, unable to go to senior centers or to schools. So we did grab and go meals. We gave out millions of meals. Why didn't we use that opportunity to reintroduce people to a healthy meal source? We would have strengthened immune systems. We would have introduced people to new eating habits, since they were a collective audience, because we were feeding millions of people in the city, in the state, in the country. This was our opportunity to say, number one, we're going to help you strengthen your immune system due to COVID-19. And number two, we're going to start changing the foods that you're eating and give you healthier meal. 90% of the people who were hospitalized had comorbidity. 90% of the people who died had pre-existing or comorbidity. They're all food connected. All of this is food connected. And your audience must be clear. Every chronic disease that I had when I walked into that doctor's office 3 months later was gone. Gone. No medicine, food. I did 1 week of medicine, 1 week, because medicine should stabilize your condition. It should not become permanent in your life unless there's a reason. There's some reasons you do have medicine as part of your life, which we have a great medical system. We're good at chronic illness. We're terrible at chronic diseases.
Okay. Excellent answer. There is a question in the chat, and the question is, Borough President Adams, who offers the nutrition program in Brooklyn?
We're doing it through the school. We were able to get the mayor. You know, I just finished a book, Healthy at Last, to talk about from slave food to soul food is still a dangerous food. And we are going, we're reaching to our children, empowering our children. We walk around with the NAACP's resolution. You know, we talk about our oldest civil rights organization has taken upon the real Jim Crow, and that's the food crisis. I'm just really excited about it. I keep it with me all the time and talk about here's what the NAACP is doing. So we're really encouraging our schools to do nutrition-based education, re-examination of home economics, but this time showing children how to have healthy food, spices. We were able to get many of our hospitals and our other agencies to go to plant-based meals, but the reluctancy we're having is because many people who are in decision-making positions in government that feed people don't believe we can heal people, and we're not seeing the connection between what we're putting on our plate and what is making us go to the hospital. So that is the biggest battle we're having, to try to show those who are the decision makers, who's doing the procurement, why we need to change what we are purchasing and serving to people who are already in crisis state. If you do an analysis of the homeless population here in New York City and in New York State, you'll find that overwhelmingly they have comorbidities. Yet we're feeding them food that causes that comorbidity. So our goal is to educate those who are in head of agencies so that we can have that part of the overall plan to improve the conditions of the people we are attempting to assist.
Okay, those are excellent answers. I have a question now for Dr. Demisi. Dr. Demisi, I'd like to know, in regards to your presentation, is it possible for someone to get COVID a second time after they've had it, a full-blown case of COVID?
Thank you for the question. The answer is yes, but at the same time, I have to emphasize that it's not a common thing. It's a very rare thing that people get COVID twice. And the other thing I want to mention is usually when you get COVID the first time, the virus RNA or the virus component can stay into your system up to 6 weeks. And a repeat test can actually show that you are still COVID positive from the first infection you had. But there were a lot of studies done taking into account the interval between the first COVID and the second COVID infection. And clearly, very small number of people developed COVID with clinical symptoms, and also their test was positive. In addition to that, the viral culture actually shows active virus in their system. But what is not known is whether they are really getting a new infection from outside or whether it is a reactivation of the virus that is already dormant in the system is not known. But there are few documented cases where there is second infection of COVID.
And one last question. Is there a comorbidity that puts a person at higher risk for having poor COVID-19 results? So if a person gets COVID-19, is there one of the comorbidities, diabetes, hypertension, any one of those puts you at a worse risk of developing more, your end results being worse? That's really cool.
Yeah, I think as President Eric Adams stated clearly, there are many, and the comorbidities can be classified into 2 clusters of comorbidity, but obesity with a body mass index above 30 is a significant risk factor. And the other second condition, which is very, very important, is diabetes mellitus, because the disease is affecting the blood vessels, the small blood vessels, through inflammation and infection. It's a vasculitis that it is creating COVID-19. The diabetes mellitus is another important comorbidity, which is associated with a bad outcome. But there are a lot of other diseases like sickle cell disease, cancer, chronic kidney disease, people with organ transplantation, heart disease, hypertension. All of these are at higher risk, including chronic lung disease. But obesity and diabetes are very significant in this.
Okay, thank you so much for your answer. Dr. Salifu, I don't see him on the screen, but I have a question. You're here. Oh, there you are. Okay, thank you. I wasn't seeing you before. My question to you, you put in the last, one of your last slides, an idea, your idea of the best way of providing healthcare delivery in our communities. You said, and this would create a linkage of care from the patient coming into the hospital, moving on their patients, and then moved on to CBOs, community-based organizations.
Right.
Once they reach the community-based organization, they're no longer linked together back to the hospital should in case something happens. The whole thing has to start all over again. Can you just briefly tell us about that model of care?
Well, first of all, thank you, NAACP, and you, Lorraine, for putting this fantastic program and inviting me. I also thank my fellow panelist, President Adams, who has been very supportive of the Brooklyn Health Disparity Center. very much so, since he came into the office. Anyway, so the work that we do in Brooklyn is basically trying to help everybody else, including the president, to reduce health disparities in Brooklyn through research. That is the part that we do, we weigh heavily into. We try to take the theory and then we try to prove it and then put it into practice. But the model that I came up with in the presentation is because of just long-standing, debates around the issue. Everybody is trying to solve the problem, which is good, but they are not connected in a way that is consistent and in a way that is a solution that people can actually tap into without the extra effort. So along those lines, we came up with this plan that if we had, patients are always coming. We have the safety net hospitals and we have the non-safety net hospitals, and people actually come for care. Minority communities come for care, low-income people come for care, and so on and so forth. So if people are actually coming to you and then you are seeing them and then just discharging them with 7 or 8 medications like the president said, then you are basically not doing what you're supposed to do. If you have a motivated, highly motivated individual like the president who can actually do it, you can actually do it. What if you're not as highly motivated and you're supposed to be connected to somebody else who would then help you to do it? Then what do? That is the genesis of this model. So we have a lot of people coming into the health system, and I classify them because they have social determinants. I classify them as high risk. That is why the image is red, as high risk for social determinants, and they're entering the health system. About 80%, maybe 90% of the health systems in New York City right now have electronic health record systems. And all of these health record systems are actually linked to a few, maybe 3 or 4 major electronic health record systems, like Epic, like Allscripts, right? So there are centralized processes for creating these kinds of programs that can allow somebody to be detected very quickly in an electronic health record system. Why? Because the data is already in there. The person is coming, the name, the date of birth, the age, where they live, the zip code, the insurance status, all the various factors that you can actually use to calculate the social determinants are actually in the electronic health record system. But there's no program within it that would actually label the patient as high risk or low risk.
Okay, Dr. Salifu,
Yes.
in interest of time, we have 30 seconds left and we're trying to wrap it up. Perhaps we can finish this up or, give more information as time goes on.
Sure.
Just to close what he's saying is that COVID-19, because we had such disconnect in the healthcare delivery system, a program like what he mentioned would link us better. And if we can get a program like that put in place, moving forward, any tragic health condition coming into our communities could be better addressed and we won't be in a panic state.
Exactly.
Really, that's really what this program, as I understood it to be.
That is correct.
Okay. So thank you, everyone, and we'll try and see how we can answer the rest of the questions that are there.
Well, thank you very much, Lorraine. This was a absolutely fantastic panel. I want to thank the doctors and also Borough President Adams. I will tell you, Borough President Adams, I just ordered your book because I know what's going to happen. Okay, so it is available October 13th. I ordered it and it's going to be at my house October 28th, which is my birthday, which is a sign that I need to get my whole entire family on a plant-based diet.
Absolutely.
So this was really, really good. And for any of the other doctors, if you have written a book, please let us know because we will post all of the information in the chat. This was fantastic. I mean, because all of you are absolutely right. We have to take more control of our health and our diet. So Lorraine, absolutely fantastic, fantastic job. So thank you very, very much it's a great panel, great presentation. And one of our participants, Michael Griffin, was eating as the presentation was going on. So I'm gonna call and find out what he was eating and we're gonna let everybody know, okay? All right, thank you very much.